Hello and welcome to Sick Notes. My name's Dr. Ed Hope, and on this channel we talk about medicine. I share some of my experience of being a doctor in the UK. I've done quite a few TV medical show reviews, and so I put it to you guys to see which show would you like me to do a little bit more of, and there was a narrow victory for House. Although it was so narrow, I'll probably look at doing some episodes of the other shows as well. I was a huge fan of House when it was on air, so I thought, what episode could we look at? On iTunes there's a collection of fan favourites. I thought, why don't we look through them? And the first one is the episode 3 Stories, which is episode 21 from the first season. If you guys remember that, it's a pretty crazy episode. It's unlike many of the episodes of House, but also there's a huge revelation at the end. So if you haven't seen it yet, I always talk about not having any spoilers on this, but these shows are quite old now, so hopefully if you're interested in House, you've already seen the episode. As I said, it's an unusual episode. It's quite a comic episode, so I'm not expecting it to be super accurate. It's supposed to be extra dramatic, isn't it? So it's a good chance just to revisit the episode. I can explain a little bit more about what's going on screen and share some of my experiences of a doctor. So let's dive into it.
I'll do the lecture for 4 hours off clinic.
2. I know you'd rather spend a couple of hours listening to yourself than listening to patients. Class starts in 20 minutes.
So we see House is being bribed into teaching medical students. So House ends up delivering a lecture on diagnostic medicine. This is pretty bang on, actually. When I was at medical school, most of the lectures were delivered by academics within the faculty, but then occasionally, maybe once a week, we'd have a clinician, so a doctor currently working in a hospital would come and do a kind of guest lecture. The quality of them were always pretty varied, but actually they weren't too far off this kind of relaxed attitude.
3 guys walk into a clinic. Their legs hurt. What's wrong with them? I'm not gonna like you, am I?
The most likely cause of leg pain is muscle strain.
The most likely cause of leg pain is muscle strain. That is a really intelligent answer. I like that. The cliche of medical students is that they come up with the most obscure answer first. So he said, what's the cause of leg pain? Some will say like bone cancer. The way we learn medicine is really about how to organise your thoughts. So how to come up with what we call a differential diagnosis, what might be going on. So for leg pain, a good way is just to think of what the leg is actually made of. So there could be something wrong with the musculoskeletal system, so things wrong with the muscles, with the ligaments, with the tendons, with the joints. As said, this is probably the most common cause of leg pain. It's also made up of blood vessels. So there's arteries, blood vessels that come from the heart, or veins, blood vessels that take blood back to the heart. Either one of these could be blocked or damaged. So we could have what we call claudication, that's a blockage of the artery, or we could have something like a deep vein thrombosis, so a blood clot within the venous system. We also have lots of skin and soft tissues in the legs. So there might be a source of infection, something which we call cellulitis or ulcers. So that would be a kind of good way of organising your thoughts for leg pain. And when you organise your thoughts, it's important to remember the common things that we've already mentioned, but also the uncommon things that you don't want to miss that can be potentially serious.
What were they doing when pain presented?
I have no idea.
You didn't ask? You didn't take a history?
Of course. But all that told us was what they said happened.
Taking the history, basically just asking the patient what happened, is the most important thing you do when diagnosing a patient, which may surprise a lot of you. Obviously, many conditions are formally diagnosed with blood tests, imaging, that type of thing, but the history allows us to figure out what might be going on so we can order the correct tests. I don't think this is fully appreciated by the public, how important a kind of what we call a clinical diagnosis is. Just last week in A&E, I had a gentleman come up to me who'd come in with chest pain, and he was waiting to be reviewed by a doctor. Now, he had blood tests when he came in, and he came up to me at the desk and said, how long's the wait going to be? So I gave him an estimate, and he said, well, I can't wait for that. Can I just see if the blood test's all right and I'll go home? Now, if I'd have just looked at the blood test and sort of seen, oh, everything's fine, you can go, that still doesn't mean he's safe. Blood tests can tell us a lot, but only in the context of what's happening with that particular patient. For example, if he'd had pain just a couple of hours before the blood test was taken, that's too early to pick up any changes for something serious like a heart attack. Kind of like just looking at the engine oil and then deducing that everything is perfectly fine with the engine and the car. So although House kind of dismisses the history here, because he's kind of a genius, he can deduce all these things from the history in a kind of different way, but most doctors don't have that ability. So as a principle of medicine, taking history is super important.
Person A, farmer, says he was fixing a fence. Person B, volleyball practice. And C, we've got Carmen Electra, golfing.
So this is really well done, actually, very accurate. We have 3 patients with leg pain, a farmer, a volleyball player and a golfer, and this is exactly how I deliver my lectures for a system. I always pick 3 cases and then talk through each one, and throwing the questions over to the students, trying to get them to picture what they'd be like in the doctor's shoes and what they'd do next. And that's a really nice way of learning.
I say we start with the farmer. Did you hike to the fence, and how far?
Yes, it's about a half a mile from my farmhouse.
And where is the pain localized?
So first up, the farmer, and House does a pretty good job of taking a history here, even though he was belittling it earlier.
So, what should we do first?
Family history?
Indicative of leg pain, that's a very short list. Any history of bone cancer?
I mentioned this before. Imagine going to a doctor with leg pain and, you know, the second question they ask you about is bone cancer. Oh. This is where it comes back to being systematic. So in general terms, if a patient's stable and we take a history, we think about the history of the presenting complaints, so what's brought them into hospital. We then ask them about their past medical history, so we can find out if anything is, you know, they've had similar things before or any conditions that could present in that way. We then talk about drug history and allergies within that. Then we talk about their family and social history. And then we do what's called ICE, so their ideas, concerns and expectations. That gives us a general idea of the priority of questions and make sure we don't miss anything.
Could be a blood issue. We should run a CBC and a D-dimer.
The second student's offering isn't much better. Let's do blood tests. We talked about this. If the patient is stable, we take a full history and examination. Then we do investigations like blood tests, and then we do management. Otherwise, we'll do these tests, and if everything's normal, we'll have to go back to our history and things like that. So we go through this systematic approach.
And get an MRI.
MRI or a PET scan?
And then the dude that's used to be in 10 Things I Hate About You says, then an MRI. Yeah, again, it's an investigation. We'd want to do that a lot later. It would take us a bit of time to get that as well.
Sorry, thanks for playing. Patient's dead. You killed him.
We had no time to run any tests. There was nothing we could do.
You had time to look at the leg.
So it's a nice little touch that they've added this in to show where medical students are and then ultimately how House sees things and where the students need to get to. Weirdly, because it's a story that House is telling, this patient suddenly turns into Carmen Electra from Baywatch fame. It goes without saying that this kind of perving on a patient, even in a fantasy, is a little bit weird, Greg. Sort yourself out.
Puncture.
Snakebite.
That would be my guess.
So the patient has a snake bite. In the UK, I think we only have like one type of venomous snake and it's really uncommon. So I literally know nothing about snake bites. I can imagine any doctors in Australia and America and other parts of the world, this is a super important thing to know about though. I have no idea if this is realistic, but I can guarantee that the doctors would not be there with the, I guess it's called a snake wrangler, sounds a bit naughty, trying to catch the snake, but they do a good job. They identify the snake and give the patient some anti-venom.
200 milligrams. Our guy got bit less than 4 hours ago. There's no way a snake regenerates that much venom that quickly.
So House notices that the venom test from the snake has too much venom in his fangs, therefore couldn't have bitten the patient. I mean, That is some next level knowledge from House, but don't forget he is telling this story to a bunch of medical students in the room, so he has total control over how he paints this picture. And so when I deliver these kind of clinical lectures, I sort of do a similar thing. You know, you just sort of slightly bolster up your clinical ability when telling the story. It's a nice way of looking smart and helps your ego endlessly. Of course he's right, and the antivenom doesn't work and the patient continues to get worse. So then House asked the medical students in the lecture theatre, what should they do next? So should they give the patient the next most common type of antivenom, or should they not?
Who gives the guy the other antivenom? And who goes looking for the snake?
I assume that one choice kills him, the other one saves him.
That's usually the way it works at the leg turning black stage.
This is a really interesting question, just in terms of general medical questions. So we very often treat a disease that we suspect, even if we haven't diagnosed it yet, if the treatment that we're giving is quite low risk and well tolerated, and the delay in trying to get the diagnosis can make the disease significantly worse. So just off the top of my head, something like a pulmonary embolism, so a blood clot in the lung, we treat with blood thinning medications to help the clot reduce. We'd do that straight away without waiting for a scan to confirm that there's a blood clot there.
How do they teach you how to tell someone that they're dying? Do you role play and stuff?
Yeah, one of us gives the bad news and one of us gets the bad news.
What do you have to do to get an A in You're Dying 101?
We do get taught how to break bad news. I understand where House is coming from, like how can you give someone an A in telling them that they're dying? Because it's so hard, I think as doctors, when you're first learning to do it, you can often trip up on your words and not find the right language, because you're so aware of sort of being insensitive and saying the wrong thing. So the role plays you do as a med student are actually really good. Although you obviously don't totally connect, it doesn't have the gravitas, you actually helps you to find a language and helps to find a pace in which to deliver things. And there's also some kind of key aspects that are shown to be a good way of delivering this type of news. So introducing yourself properly, having a good environment, so making sure you're not going to get bleeped when you're delivering the news, making sure the patient has everyone around them that they wish to have around them, asking the patient how much they want to know about what's going on. Some people don't. And then from there, we often do what's called a warning shot. So we'll say, you know, I have some bad news for you, just to set the patient up for what they're about to hear. And then you just tell them straight.
It wasn't a snake bite, was it? I said I don't remember being bit. The good news is you might just live. The bad news is your dog's gonna die.
So eventually, in talking to the patient, House figures out that it isn't a snake bite, but a dog bite that has become infected. So, you know that part of the history where I said you talk about the family and social history and the ideas, concerns and expectations. The reason why the patient was holding it back is they didn't want their dog to be put down, their dog to be killed, because it's bitten the owner. So, you know, maybe House should have spent more time trying to get the history, even though the patient was kind of holding it back. He might have got more information there. And is this realistic as well? I mean, as I say, I don't know anything about snake bites, but I would like to think that I could tell the difference between a snake bite and a dog bite on a person's leg. Also, any significant bite, snake bite, dog bite, human bite, you would treat with antibiotics, because all of those mouths contain lots of nasty bacteria that if they get under the skin would cause a problem. So you would expect this chap to already be on antibiotics and the team to be thinking about that, regardless of what animal has actually bitten the patient.
The lab test of your dog's saliva revealed a type of strep bacteria. It's commonly known as the flesh-eating disease.
This nasty flesh-eating bacteria is absolutely true. We call it necrotizing fasciitis. The worst case I've ever seen was a gentleman that had it around his thighs and around his genitals, something that we called Fournier's gangrene. I don't recommend you Googling it. It literally looked like he had his whole saddle area kind of bitten by a tiger. It was just completely destroyed by this infection. It is very serious and has a very high mortality, so you have to clean all the tissue away, give the patient lots of supportive care as well in terms of fluids and antibiotics. So the patient has his leg amputated and he survives. So that's one case done. So on to the volleyball player, and the working diagnosis is tendinitis. So what is tendinitis? So tendons are things that connect your muscles to your bones. So as opposed to ligaments, which can connect your bones to your bones. Itis means inflammation, so therefore tendinitis means inflammation of the tendon.
How old is this person? I mean, it's not really a 40-year-old man on the girls' volleyball team, right?
It's a leg. Leg's a leg's a leg.
It's funny that House pulls them up on asking the age of the patient. The age is super important in a patient. In fact, when we're presenting a case back to a consultant or we're writing in the notes, the first thing we write is the patient's age and sex. I mean, common sense will tell you that certain diseases are more prevalent in certain age groups, right? So that's why it's really important in, you know, locking your thinking into what might be happening with this patient. So I'm a little bit surprised that it's kind of downplayed a little bit here.
Discovered a tiny nodule, which in reality signified nothing, but gave us no choice but to put a person with tendinitis through an expensive and painful test.
So we're already told the learning of this case, and it's super applicable to medicine. Don't over investigate things. If someone comes in with a clear history and examination consistent with a tendinitis, then we can just treat them with anti-inflammatory medications, rest, and give them some safety net and advice if it isn't improving, where to get help. And that's it really. So only if the patient didn't improve would we do things like this, like spread a wider net and do blood tests and imaging and things like this. And so in this episode, this patient eventually undergoes an invasive biopsy of the thyroid gland and a biopsy of the bone in the leg to look for bone cancer. So it's a really nice little case highlighting this kind of important medical concept and not to over-investigate things. And the final case, the golfer, it's the one you've all been waiting for, isn't it? Let me tell you why. So the patient is in a lot of pain here. In the emergency setting, controlling pain is so important. I've heard a bit of a fallacy that we don't like to give too much pain medication because it might mask what's going on, which is just absolute rubbish. In our where I work, in our A&E clerking card, after the patients what they've come in with, the next box is how much pain they're in, to encourage us to address that so the patient's more comfortable. It's also a really important kind of diagnostic thing to see how responsive the pain is to medication. It can help you figure out exactly what's going on. Patient responds to analgesia really well initially, which makes the team think they may be doing kind of drug-seeking behaviour, so just faking the pain to get free morphine.
We're going to put this hard rubber tube up your urethra and into your bladder.
Oh God. So House devises this extremely unethical test to figure out if the patient is faking it. Okay, this just wouldn't happen, but the theory behind it in this episode is that no one would consent to having a catheter, so a rubber tube put into the penis that goes into the bladder. No one would consent to having that done unless their pain was genuine. But even worse than this, they show you the catheter here and the balloon is semi-inflated, so that's even worse. So that balloon that you see in the shot there is, once we've passed the tube into the bladder, we put some fluid through the bladder and that fills the balloon up and that keeps the catheter in the right place. So there's no way you'd even get that into the patient with the balloon semi-inflated. It would be so unbelievably painful even just trying. Having said that, it's going to make your eyes water a little bit. I have seen patients who have been confused actually pull their catheters out with the balloon still inflated. I mean, it just must have been so painful. I actually don't even know how that's medically possible. Presumably all the tissues just stretch a little bit. So the patient accepts the catheter, so presumably they're not faking the pain, and the catheter drains some dark tea-coloured urine. So putting that in the context with leg pain, the team think it would be muscle breakdown. Now, we find out at this point that it's been going on now at this stage for 3 days. And we find the big revelation.
His MRI showed that the leg pain wasn't caused by the self-injection, wasn't caused by an infection. It was an aneurysm that clotted, leading to an infarction.
God, you were right. It's House.
So this is the story how House got his chronic leg problem, how he got his addiction to morphine type medications, and also, I guess, part of his personality, so how it led to him being quite a cynical doctor. Is this diagnosis realistic? I would say absolutely, but a big caveat, 3 days, that's pretty extreme. That tends to be a kind of common thing in House, actually, is that everything's sort of realistic, but the timings are always a bit obscure and things are often missed for convenience sake. So the problem was caused by an aneurysm. So let me tell you exactly what this is and how it caused House's problems. So here is an artery in the leg. To remind you, an artery is a blood vessel that carries blood from the heart to the tissue, and because of this it is under high pressure. An aneurysm is a weakness in the blood vessel wall. Over time, due to the weakness and the blood pressure, the aneurysm will expand. In itself, this may not be an issue, but complications can arise. For example, because the wall is now thinner as the aneurysm expands, it may rupture or leak. This can be potentially fatal if the aneurysm is formed in a large blood vessel, like the aorta, or in a blood vessel in the brain. Now, what House had was a different type of complication from an aneurysm, what we call a thrombosis, sort of commonly called a blood clot. And your blood doesn't usually thrombose in your blood vessels due to 3 things: the specialist lining of the blood vessel wall, the smooth flow of blood through the blood vessel, and the specific makeup of the blood constituents. These 3 things are called Virchow's triad. A change to any one of these 3 can cause the blood to thrombose in the blood vessel and therefore deprive the tissue of oxygen that is supplied by that blood vessel. So in an aneurysm, we have changes to the blood vessel wall because it's become thin and damaged, and we have a disruption to the flow of the blood because of this bulging of the wall. These 2 things mean that a thrombus can be formed. In House's case, this blocked up the artery, meaning the muscle that was supplied by this artery became starved of nutrients and began to die. On examination, the lack of blood supply would mean the limb would have certain signs and symptoms that we remember as the 6 Ps. Well, let's see if I can remember them. So the limb becomes very painful, it becomes pale, it becomes perishingly cold. That's a bit of a shoehorned P in there. We have paresthesia, so we get funny sensations. We get paralysis, so we lose some of the muscle loses its ability, so we get weakness. And finally, what's the last one? We lose our pulses, so it becomes pulseless. Any tissue death caused by a blockage of an artery from a thrombus we call infarction, and any dead tissue we call necrosis. Therefore, to restore the circulation, a vascular surgeon would either put a stent, a tube inside the artery to keep it open, or do a bypass. That is to take a blood vessel from somewhere else and stitch it so it goes round the blockage in the artery. There are a few other complications that happened in House's case, but essentially the muscle was so dead that it had to be removed, and this led to his chronic leg pain. So there you have it. We talked about loads of things today. What happens at med school. We talked about the importance of taking histories, the importance of not over-investigating, the sort of normal thought processes doctors go through. We've learnt a little bit about blood vessels, infarctions and aneurysms. We talked about why House got his chronic leg pain. So if you enjoyed this, you might want to check out my previous House videos or some of the other medical TV shows I do. Finally, thank you again so much for all your support on the channel, for the likes, for the shares, and I absolutely love the comments as well. Love reading the comments and hearing from you guys. So thank you again, and I'll be back soon, and I'll see you then.